So fenestrated stent grafts, we use this procedure whenever we have to do complex coronary aortic aneurysms. So whenever there is a visceral branch involved, to protect the visceral branch like renal arteries or superior mesenteric artery or a subclavian artery, when you cannot sacrifice them, then you have to do fenestration. So fenestration, the concept started in 1998, and the success rate is as high as 95%. With a good experienced people, the mortality is in the range of 1 to 5% for pararenal and 5 to 10% for thoracoabdominal aneurysms. So initially the fenestrations were started only for both the renal artery, to protect the renal artery. Whenever you don't have a good neck for an abdominal aortic aneurysm, you extend the stent graft above the renal artery and you protect both the renal arteries by doing fenestrations. So then as more and more expertise came, we started doing two vessel fenestration, triple vessel fenestrations. So these fenestrations were first used, as I said, for renal arteries, and then we went on with doing for superior mesenteric arteries, and then fenestration were done both the left carotid and left subclavian artery when you have to cover arch of aortic aneurysms. So the issue of the challenging neck, whenever you have a challenging neck, that is especially an abdominal aortic aneurysm, you keep the covered stent above the renal arteries. So the strategies to fix this neck problem is physician modified endografts, that's or use as a snorkel or a chimney procedure or a periscope to do the perfusion of the renal arteries. And these can be custom made, which take a lot of time for them to design and they come back and they're more expensive, or you can do fenestration in cath lab and use these stent grafts. So then what is snorkel, chimney and endovascular repair? These are the terms. The chimney is when you use a covered stent parallelly along the stent graft and the blood flow from the above, it's called a chimney. And if the blood flows from the retrograde, that is called periscope. So the direction of the flow, it's called either a chimney or a periscope. Basically these are outside the stent graft and they perfuse the renal arteries. The problem with the periscope and chimney, these are the bailout procedures when you are not able to cannulate the renal arteries, the bailout procedures. And these chimneys and periscope, they don't last longer. That's why the concept of fenestration came. And then there's more endo leak with this chimney and snorkel procedure and periscope procedures. So it depends on each stent. You should know the stent, how it is designed, where you can make a fenestration, and how the stent is there, where you can make an access. For example, the Zenith fenestrate has 3 components: a proximal main body, a distal bifurcated main body, and one iliac limb. It has a woven polyester fabric and a self-expanding stainless steel stents, which are secured together as a composite endograft. So the main body can accommodate a combination of 3 fenestrations or scallops. Thereby we can maintain the visceral arterial patency. For example, if you have you want to do a superior mesenteric artery fenestration and bilateral renal fenestration, you can make 3 fenestrations in the main body and you can do the procedure. The scallops are nothing but they represent a U-shaped gap within the proximal fabric of the stent graft. The scallops are normally 10 millimeter wide and their heights can be up to 6 to 12 millimeters. This is again a situation of where a superior mesenteric artery, you don't need to do a stenting of the superior mesenteric artery. So just to do a scallop and protect the superior mesenteric origin, and then you do fenestration for the renal arteries. So how you do the fenestration, the technique is the custom design of the scallop and fenestration. The proximal main body is introduced with proper orientation confirmed by an overlap on anterior row of vertical and posterior row of horizontal markers to form an axis. This correct orientation is very important. Otherwise, when you open the stent graft, if the fenestration doesn't open across the renal arteries, you might have to sacrifice the renal artery, or you have to bail out and protect the renal perfusion. So then once you partially deploy the stent graft, which has a fenestration, you selectively catheterize these target vessels. This is very, very important. For example, when you do AAA, you do selective catheterization of the both renal arteries before you deploy the stent graft. And if you cannot catheterize, then you have to do bailout procedures. So whenever you do elective cases, the fenestrated stent graft occurs. And whenever a cranially direct renal arteries you can do, whenever your upper extremity occlusive disease you can do these fenestrated stent grafts. So these are our experience in KIMS hospital. We have done more than 10 fenestrated stent grafts. We have done chimneys, periscopes. I'll just go with some of the examples which you have. You can see is a saccular aneurysm in the abdominal aortic artery, and the left kidney is non-functional, is totally occluded. Patient is having a single kidney and this is a sacral aneurysm, this is a right renal artery here, and this is a supramesenteric artery here. So if you want to do this sacral aneurysm closure, you have to keep two fenestration, one supramesenteric artery and the right renal artery. So this is the stent. We have made fenestration as depicted in the picture. This is from the Ankura device, LifeTech. And this we made a fenestration, and through the fenestration, we have gone with the catheter, the fenestration made in the graft, and through that, we have passed a B graft peripheral stent, and we didn't successfully stented this procedure. But unfortunately, we couldn't cannulate the right renal artery. If you see, the right renal artery is totally occluded. So we couldn't cannulate the right renal artery. So we tried 2.5 hours to cannulate this right renal artery. Then this is a flow across the supramesenteric artery, which is flowing very well. And then we could access the right femoral artery through a PTCA wire from the femoral root. But this was not getting enough support. So what we are forced to use a hard end of the termo wire, come from the transbrachial root and cannulate this fenestration of the right renal artery. And then we could successfully stent this renal artery, and you could get a protection. So if in this case we couldn't have protected the renal artery, would have lost the renal artery, patient would have gone to renal failure, and would have been big catastrophe. This is a second case example, complex aneurysm. He has a thoracic part, there's an aneurysm here, and there's abdominal part aneurysm, there's no landing zone, and both renal artery has to be protected. And you can see the extent of the disease here, and the huge aneurysm below the supramesenteric artery, and there is no neck. So you have to stent graft in the thoracoabdominal part up to the celiac artery, and then we have a good landing zone, and then we can, below the supramesenteric artery, you can keep the stent graft with both fenestration. So we already deployed the upper stent graft, and the second stent graft we have taken, and with both fenestration in the renal artery. And you can see there's a gap between the first stent graft. The last stent graft in the last stent is a bare part, so it's not occluding celiac artery and supramesenteric artery. And now once we want to deploy, you can see the fenestration in the graft. Here when you are partially deploying, you can see both fenestration well there. So once you partially deploy the stent graft, you cannulate the supramesenteric both the renal arteries. This is a right renal artery fenestration, and we have cannulated the right renal artery fenestration through the endograft. This is partially deployed, and we put a wire, we put a hard end of we keep a amplitude stiff wire and protect that. And then we try to cannulate the left renal artery. This is the guiding catheter in place. And then we put a catheter in the left renal artery. We put a hard wire, amplitude stiff wire. And then we pass a catheter. And then we pass the guiding catheter. And keep all these things ready before we deploy the stent. So both renal arteries are cannulated well here now. And the stent is still not deployed. And now once you have accessed both renal arteries, the stent is deployed. And then you can see the stent deployed here. And then we're doing bilateral renal artery stenting with a covered stent, so that the endo leak will not occur and there will not be any leak. So this is how both the stents were deploying, and you can see those two fenestrations there. And this is a good perfusion of the both renal arteries, and you can see the final result here. And you can see the final here, both renal arteries are perfused, and this patient is doing fine after 3 years. So when you do these type of cases, you need a lot of team efforts. You can't do it alone. You need your colleague support. So we have excellent support from our colleagues whenever we need a bailout situation. So we had a very peculiar situation in the case 3. This patient had an abdominal aortic aneurysm. So we planned for a bilateral fenestration here. And this is abdominal aortic aneurysm. And you can see the fenestration there, and both renal arteries are perfused in another picture. And then this is a abdominal aortic stent graft, partially deployed with both the fenestration there. And then we deployed the stent. If you can see the picture again, the left renal artery is not seen, and we are not able to cannulate the left renal artery, and we didn't want to sacrifice the left renal artery. So we at least make sure that right renal artery is protected. We put a catheter there and protected. You can see now in this picture there is no left renal artery. So what we did, we went outside the aneurysm, outside the stent graft, and we put a catheter, and you can see there is still the renal artery is perfusing. So there was some hope. So the problem, what happened here, the fenestration which it did on the left renal artery got collapsed. It was not opened fully to cannulate the left renal artery. So what we did, you can see that we are pulling the balloon there. So we went outside the aneurysm, went into fenestration into the graft, opened the fenestration, and then we got an access from the stent graft into the renal artery. You can see now it's very easily gone there. So you need, this is what we do when in LAD diagonal, sometimes diagonal is occluded, you're not able to go to the stent, then you open the stent, cannulate the diagonal, again cannulate the diagonal through the stent and open the diagonal. That's what the technique we used here. And then we could successfully pass a stiff wire there, and there's a stent going there with lot of difficulty, tortuosity, and this is again a covered stent there, and we could perfuse the left kidney. So whenever you want to do these complex fenestrations, you need a good tip approach, you need a people who can come up with fresh ideas, then only you can bail, otherwise we have to sacrifice the visceral organs. And you should have a lot of experience like before you try to do this fast fenestration. Thank you very much.